Right. Good morning, good afternoon, good evening from wherever you are signing in on around the world. Good day, everyone. My name is Ali Shahzada. I am the Executive Director of the Value Collaborative, and on behalf of myself, as well as Carolyn Hoffman and Ina Ajula, thank you and welcome. On behalf of ISMP Canada and the Value Collaborative, welcome to this webinar called Driving Medication Safety in Community Pharmacies Through Continuous Quality Improvement. I hope that you get a lot out of today. It's an action-packed session, a lot of information going to be coming at us. Please feel free at any time to use the chat window, use the Q&A feature to ask any questions, make any comments, and we'll see how we can answer those questions as they pop up. Now, based on our head offices at Value Collaborative and ISMP Canada, we're going to do a little bit of a land acknowledgement. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and Inuit peoples. We are grateful to live and work and play on this land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. Again, as I mentioned, this is based off of the head offices of ISMP Canada and the Value Collaborative, which is in the Toronto GTA region. If you want to recognize any peoples yourself based on your location, please, in the chat window, feel free to make mention of that. So, given that you are here today, I would assume that you have some interest in quality improvement. Not only quality improvement, but the idea of how to apply it in a community pharmacy setting. As such, we have 3 major objectives for today to get to you. The first is to give you an idea of what is continuous quality improvement. And we may have heard these terms called Lean or Six Sigma in the past. How do they connect to this idea of continuous quality improvement? The second thing we're going to be talking a little bit about is showing you some real life examples of how these tools have been applied in a pharmacy environment. One from a long-term care home perspective and medication errors, and the other from a true community pharmacy and seeing how a lot of these tools were done to reduce errors there as well. Last but not least, we're going to be talking a little bit about how do you start to build a culture of continuous improvement or continuous quality improvement within your own organizations? What are some things that you may want to consider as you are building that? So with that, let's go into a little bit of a detailed agenda. Like I mentioned, we'll talk a little bit about introductions. Who are we? Love to know who is around the virtual room here today. Talk a little bit about what's the burning platform around CQI. Why are we working on this? What is Lean Six Sigma? How do you start to approach problems with this CQI mindset? We're going to give you a quick 5-step process to start to solve problems going forward. Again, we'll mention 2 real case studies on how to make improvement, how these tools have been applied in real pharmacy world. And we'll talk a little bit about what the components that are necessary to kind of build this culture. In the end, we have a question for you. We would love to see your interest in quality improvement, and we have some quick questions that we would love to ask you. So please stay tuned for that. Now, with that, I'm going to hand the baton off to Carolyn Hoffman, CEO of ISMP Canada. Carolyn?
Thank you, Ali, and welcome everyone. We are really excited to have you here today to focus on CQI, Continuous Quality Improvement in Community Pharmacies. A little bit about ISMP Canada, you may know, but it's important to make sure who are we and what do we do. We've been a trusted partner for over 20 years with the cycle of learning, sharing, and acting to improve medication safety. We are national, independent, not-for-profit. We are very clearly independent in any recommendations we make with very explicit funding requirements and transparency. Our learn, share, act cycle is right there for you. Won't read all of the details, but I will highlight one important thing. We learn about what's going wrong through a variety of mechanisms. The one I want to highlight today is reporting into our National Incident Data Repository for Community Pharmacies. NIDR. So that's a very important pathway. 6 provincial regulators in Canada have various CQI, continuous quality improvement requirements, and part of those requirements include mandatory reporting. They're not always called medication incidents. They have variable terms across Canada, but the point is there is required reporting when something goes wrong. And those incident reports flow into ISMP Canada. And I want to just flag, and as you can see, Ina Agila is on today. She's our Director of Community Pharmacy Reporting and Learning, and a very key contact for you. So please do reach out to any of us, including Ina, on an ongoing basis. So with those reports, we take them in, analyze them, issue recommendations, and then partner to act. Today, we're partnering with you. We think there's some very important capability and capacity building in this area, and we have a brief time today with you to share some of our thoughts, some knowledge, expertise, and then most importantly, hear from you. What do you want further after today? Back to you, Ali.
Thank you so much, Carolyn. The Value Collaborative, I am the executive director, Ali Shahzada. We are a consulting firm focused in on performance improvement, and not only just general performance improvement, but looking specifically within healthcare sectors. So whether it be acute care, pharmacy, long-term care, emergency services, government, if it's healthcare, we can help. We have 3 major approaches to making change. The first being providing project management support or any sort of project support, whether it be any kind of problem that an organization is facing, partnering with them to help them solve that problem. The other is things like today, training, providing some insight as to, what are some methodologies that you can apply? What are some ways that we can start to build cultures of continuous improvement, or any other kind of bespoke training programs that are required? And lastly, we provide a lot of strategy support, working with organizations like yourselves to create 3 to 5 year strategic plans, adopting, again, how do we adopt a CQI culture and framework, working a lot with organizations and kind of figuring out what their vision is. So that's a little bit about us and ISMP Canada and the Value Collaborative. Again, I would love to hear who is around the virtual room here today. So in the chat window, please put your name down. What role do you have in your organization? What organization are you dialing in from? And very importantly, why did you register? What are you looking to get out of today? We have approximately 40 people in this virtual room here today. So I'm hoping that this chat window is going to get filled with pieces here. And I'd love to, again, really understand, why did you register? So with that, I'm going to hand the baton back to Carolyn here to talk a little bit about why. Why are we focused in on CQI right now? Carolyn?
Thank you, Ali. And it's very important to answer the why. This is what we think your why may be or could be. We're sharing our thoughts, what we focus on for CQI. But jump in that chat. I'll just encourage what Ali said. Jump in there and tell us why focus on CQI now from your perspective. So for us, we know the high volume of prescriptions being dispensed across Canada. You're dealing with it, you know very well. Did you know over 600 million prescriptions are dispensed each year in Canada? Staggering number. When you've got high volume and you have many Canadians, the majority of Canadians are taking 1 or more medications. And we know that medications play a key role in the health and wellness of these Canadians. It's very important to recognize that. But as you know, ISMP Canada's work is understanding what is going wrong and preventing that harm that we can. So sadly, unsafe medication practices and med errors are a leading cause of injury and avoidable harm in healthcare systems across the world, not just Canada, but we are focused on Canada. Globally, this cost is staggering. The cost to human suffering is unacceptable. So one reason we can improve the safety of our processes. On the next slide, we give a little bit more information. I talked about that NIDR database, all those reports flowing into ISMP Canada. And here you see from an article that was published in 2018, a 7-year study of what Nova Scotia regulator and system calls quality-related events. Over 130,000 events reported, 75% quality related, 82% didn't reach the patient. Excellent, excellent, but not where we want it. 0.95% or almost 0.1% had patient harm. And even though that amount is small, it still means that over 900 individuals in Nova Scotia had patient harm related to an incident. And there you can see some of the impacts. We've talked about it already. So how do we deal with that? A little bit more information on the next slide about why focus on CQI, just to help us understand the issues. Here is a January to December 2023 summary of the top 10 or the top highest number of incident types for harm level incidents reported to the NIDR from community pharmacies like yours. And so we can see the top one, incorrect dose frequency, and the high volume of that, and all the way down to other. And in between, we have things like incorrect patient, incorrect prescriber. I'm not telling you anything you don't know, I don't think, but I'm hopefully giving you really good call to action information. So we know what these things are happening. And on the next slide, and my final comment on why now, the staggering complexity of our healthcare system. Improving safety and efficiency is essential to address this and to look at processes. And as the volume of medication options increases, as the volume of your workload increases, this is the way that we don't even get more patient harm, but it's also the way that we reduce and make it safer. So again, thank you for joining today. We're here on that journey with you, and we're grateful to be working with the Value Collaborative. Back to you, Ali.
Thank you, Carolyn. So, like Carolyn highlighted, there's a burning platform, a burning case as to why we need to focus in on CQI, continuous quality improvement. I want to do a little bit of a pivot. I want to pivot it to this idea of problem solving then, because CQI and problem solving it's all interrelated. Typically, when we solve problems, what do? We are looking at that problem straight in the face. It's asking us to solve it, and we start to work on it. We work from problem to problem to problem, and it's typically a lot of firefighting. This can be very frustrating, and as I'm sure you are well aware of, it takes a lot of time from us because typically those problems that we're solving may pop up continuously. Now, I want to borrow a concept from this book called Upstream by Dan Heath, where he calls this type of problem solving downstream problem solving. This is the idea of starting to solve problems after they have occurred. They're looking at us right in the face. They've already been faced by your potential customers, your staff, and it's much more tangible because you're looking at it. Typically, this is what we spend most of our time in. He would say in this book, and what I would advocate, is we want to start to go away from the idea of downstream problem solving to something that we would call upstream problem solving. This is the idea of solving problems before they actually occur, trying to prevent the problems before they actually cause harm or cause any kind of frustration to our customers or to our staff. Now, this is a little bit easier said than done. This requires a little bit more of a system thinking approach. It requires us to take a step back from the day-to-day and try to analyze, why is this problem occurring? What is the true root cause to this? And by the next few slides, I hope to provide you a little bit of a structure that you can start to use to help you get more to the upstream level of problem solving. Now, if we know that upstream problem solving makes sense, it's kind of self-explanatory that we should be solving problems before they actually occur. What are the barriers? Why do we typically focus in on downstream rather than upstream? Well, there's three major barriers to upstream thinking. The first is problem blindness. The more you and your team are living and breathing problems every single day, the less it becomes a big issue. You become blind to it. Anyone who has children of a teenage age might recognize that they don't see the mess in their rooms, right? They think it's very normal. Whereas someone who doesn't live in that room goes into that bedroom, they're going to see a lot more mess. We become naturally blind to the types of problems that we are facing every single day. So, from a continuous improvement lens, the question that I would have then is, if we want to get ourselves away from problem blindness, is how do we start to create a culture that continuously anticipates risk so that we're not waiting until the problem is actually occurring, but rather we have some sort of mechanism in place to continuously figure out what's another potential risk that it can occur. What are some potential problems that might occur? It may occur in the future, or perhaps it's occurred in the past and can happen again. The second type of barrier that we might face in upstream thinking is the lack of ownership. Problems typically are not owned by one person. These problems pass between different departments. There are a lot of people involved, and therefore, who is actually in charge of making change? Who is in charge of improvement? That might be one of the barriers that you face in your organization. In which case, if that's the barrier, the question that I would have is, how do we create a culture of shared responsibility? How do we create a culture where everyone is responsible for making change, for making and identifying risks and opportunities for improvement? It is not your job to just come in and do the certain tasks that have been assigned to you, but also to find better ways of doing it such that the person that's coming after you doesn't have to live with the same type of problems. The third type of barrier that you could face is something around not having enough time, right? This is probably not a big surprise to you, but the idea of, the more problems that you're facing, the more burden that you're facing, you don't have enough time to go upstream and start to figure out what are the symptoms and the root causes to that. In which case, the question that I would pose to that team is, how do we make it easier? How do we make it easier for staff to solve problems? If everything has to be a large initiative, requires a lot of approvals and red tape, it's less incentive to require someone to actually make a change. Why do I want to suggest any kind of opportunity if it's going to take so much work for me to just get it approved? So these are some of the questions that you may want to start to think about if you face any of these barriers. And again, in the chat window, please, I hate the sound of my voice as much as you eventually will. So please, in the chat window, put in if you have any comments, any feedback on any of this, or any solutions to any of this, please feel free to suggest that. So we now know why CQI is important. We know what we should be trying to strive for, or what this idea of quality improvement is trying to strive for. It's more proactive problem solving. Now, what's a basic definition of continuous quality improvement? Well, continuous quality improvement is a very big umbrella term. It is a philosophy. It is not a project. It is not a time-limited thing, but rather it is an ongoing effort. The ongoing effort to improve an organization's products, processes, or services. And this can be done by either reducing the amount of waste or non-value added steps in a process, or by improving the general quality of the outcome. So the idea here that I want to really hone down to is that this is not time limited. When we say we are practicing quality improvement, it is an ongoing effort. You do not just do it once and then forget about it. It is about creating the culture of continuously looking at how do we provide a service, and is there a better way of doing it? This can be done both in an incremental way or in a rapid fashion, meaning incremental could be small changes over a long period of time. I find this very sustainable because it doesn't feel like a huge burden on staff and those who are leading change. Or you could do it in a rapid fashion, meaning grabbing a bunch of people who are working in that environment to come together for a limited time to start to say, how do we make things better? So with that notion, there's a lot of kind of thoughts that come through people's mind when we talk about CQI. A lot of times people think about improvement or continuous improvement as this idea of making people work harder, faster, just keep going, mush, 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 go faster and faster, just do more in a less period of time. Not about caring about what the patient or the customer feels in the center of it. And that couldn't be further from the truth. Continuous quality improvement, when done correctly, puts the customer in the center. The customer could be your end patient, or it could be the staff member who is benefiting from this process. But the basic idea here is, what is it that's important to this customer? And how do I make sure that this customer leaves this process satisfied, happy with what they have got? They got exactly what they needed. And we can start to remove all of the other things that are getting in the way, that are not adding value. So the definition that we use for this large umbrella term of CQI is providing maximum value to our staff, patients, otherwise known as our customers, with the safest minimum number of resources. The reason we say minimum number of resources is because, I don't know about you, but I don't have a money tree in my backyard. We have to be very cognizant about how we use our resources, whether this be time, money, supplies, whatever it may be. We need to find the best way of positioning them so that we're providing the maximum amount of value, providing more service to our customers with less of our resources, the safest number of resources. So under this umbrella term, there are various methodologies. Two of the most popular methodologies under this large umbrella of continuous quality improvement are Lean and Six Sigma. Lean is the idea, or they're two methodologies that are different, yet have over time have slowly come together because they both have a different lens, a different set of tools that can be applied to make improvement. What Lean is looking at flow. What do I mean by flow? It is the idea of, just picture a stream. You have water moving from one end to another, and the water is moving. The better the stream, the better the flow of that water. The water moves very seamlessly from one end to another. Now, if I start to put waste in that river, if I start to put a lot of rocks and garbage within that river, what happens? Well, the more garbage is there, the water starts to seize. It starts to bundle up. It does not move as seamlessly as it did before. I put too much waste in that water, it might actually block it. It might stop the water from moving one end to the other. Too much of a stoppage, and sometimes the water moves around that blockage. It's the exact same thing that happens in a process. A process is any series of actions to get from one end to another. That process could be preparing medication. It could be finishing some paperwork. It could be completing payroll. Whatever that process is, it's a series of steps. The more waste we put in that process slows down until the point where you start to see waiting happening. Too much waste, and that process can stop entirely. Or you start to see people doing creating new ways of doing it. We call those workarounds. So Lean has 5 general steps and principles that we look at of any kind of process to examine, how do we improve the flow? How do we improve the process such that going from A to Z is in a seamless manner? And you'll notice that the 5th principle here is the idea of perfection. We're never going to be there. This is the idea of continuous quality improvement. We continuously look at trying to find better ways. The concept of Six Sigma is looking at a process from more of a defect perspective. What do I mean by defect? Well, every process has an outcome. Now, that outcome can meet your specifications, meaning it could be good or it could be bad. The number of times it is not meeting your specifications would mean that it's a defect. So a Six Sigma process means that a process is robust enough that every time that process occurs, 99.72% of the time, it is going to be accurate. It is going to meet your specifications. It is going to actually be what you expected. Now think about that. And I'd love to, again, in the chat window, I would love to hear your perspective. Can you think of any process that is running at a Six Sigma level of quality? Meaning every time that process happens, over 99% of the time, it is done correctly. Please, in the chat window, I'd love for you to kind of think about that. What would be some examples of that? Are there any in healthcare, any in community pharmacy that 99% of the time is being done correctly? As you're starting to put that in there, typically a process, it falls within the 3 to 4 sigma level, which is, roughly this between, 70% to 90% accurate, which is very good, but it is not a Six Sigma level of accuracy. Okay. I don't see anyone kind of putting any thoughts in the chat window here. One example of a Six Sigma level process would be aviation, right? The flying of the safe landing of airplanes, right? You think about the millions of planes that are flying every single day. How many crashes do we hear about? They are running at a Six Sigma level of accuracy. Now, within aviation, there's a lot of different other processes. Baggage, for example, the baggage handling is not a Six Sigma process. So you can have multiple processes running at different levels of accuracy. So question that you may have right now then is, this is impossible. How do you get to a Six Sigma level process? It must be very expensive to be. And to do that, to answer that question, I want to show you a short video of how a very basic process can actually be very accurate.
Mumbai has over 18 million people. The city, it's unpredictable. But amidst this chaos, there is one thing that is nearly 100% reliable. It's your lunch delivery. The Dabbawallas of Mumbai are an institution. A Dabbawalla is a guy who delivers homemade lunches.
मेरा नाम किरण गवांदे है और मैं डब्बावाला हूँ। बिजनेस में ज्वाइन किया और तब से मैं 12-13 साल से काम कर रहा हूँ। खाली बॉम्बे में हम रोजाना 2 लाख डब्बा पहुँचाने का काम, खाली साइकिल और ट्रेन ये दोनों चीज़ों से मिलके डब्बा पहुँचाने का काम करते हैं।
This is how the system works. The Dabbawalla comes to your home and picks up your lunch. He goes to the train station where all the other lunches are. They are sorted and then delivered out into the city to be dropped off at your office. You eat it, the Dabbawalla comes, picks it up, and brings your lunchbox back home. That's the key word, home. These aren't takeout delivery guys. They're delivering you a meal straight from your kitchen. This system, while seemingly rudimentary, has been recognized as one of the most efficient logistics systems in the world. Dabbawallas have an accuracy of 99.99% in their deliveries. Per million transactions, less than 4 mistakes are made.
तो सबसे इम्पोर्टेंट चीज़ होती है कि जिस डब्बे के ऊपर जो कोड होता है, कोड में क्या होता है कि मतलब कुछ आंकड़े डाले जाते हैं, कुछ कलर कॉम्बिनेशन होता है। गलती मतलब कि कोड डब्बे के ऊपर इतना परफेक्ट डाला हुआ है कि उससे गलती होने की कोई संभावना ही नहीं है।
Crisscrossing side streets on bikes, balancing trays that weigh almost 150 pounds on their head, this group of 5,000 men, they help define the city.
बॉम्बे में कम से कम उसको 125 साल हो गए। ये सिस्टम और किसी दूसरे जगह पे नहीं चालू। थोड़ा सा हार्ड वर्क तो है, तो आदमी मतलब थोड़ा सा थकता है, लेकिन क्या वो अगले दिन वापस एक नए जोश से स्टार्ट हो जाते हैं।
These guys are out there 6 days a week, monsoon or shine. Life in Mumbai, it can be chaotic. Your train might be late, your power might go out, but damn it, your lunch will be on time.
So again, the moral of the story here is that even a very basic process, if positioned in the right way, if continuously reviewed and using a lot of fundamental principles like visual management is one here, can actually become much more efficient. So why can't other processes? So now, what is an approach that you can start to use to start to solve problems? In Lean Six Sigma, the acronym to solving problems is known as DMAIC. It stands for define, measure, analyze, improve, and control. These are the 5 steps to start to solve your problem. And they are been designed in a specific order because this is the way that we want to start to solve problems. You don't jump from one to the third to the second. We have to move in a sequential process. So over the next few slides, I'm going to walk you through what is that structured approach. The first step is to define what is it that is the problem right now? What are you trying to solve? What is your goal for this project? A lot of times when people start to make any kind of improvement, they have no idea what is truly the problem that they're trying to solve and how much of an improvement do they actually want to make. Are they looking to make 100% or 25%? You need to be very clear up front. What's the problem and how much do you want to improve that by? Otherwise, you'll have these never-ending projects. Some common tools that people can use are Kano analysis, SIPOC diagrams, project charters. These are just some examples of tools that people can use during this phase. One very powerful tool is the idea of going to Gemba. Gemba is a fancy Japanese word for the actual place. What does that mean? Well, people who practice Lean Six Sigma recognize that very little problem solving can happen within a boardroom. True problem solving happens where the work is being done, the actual place where the problems are being faced. So going to Gemba is the act of going to where the work is being done, where that problem is occurring, and interacting with the people, asking them the questions, trying to see the problem from your own perspective and trying to understand why this is starting to occur. It's a very powerful tool that can be used during your define phase, but also throughout your project journey. The second stage is called measure. In this phase of problem solving, you start to collect data. You start to collect information and start to ask questions like, what's happening? How often is this problem actually occurring? Is the problem getting better? Is it getting worse? Am I starting to see any trends here? Is this a night shift issue? Is this a day shift problem? Is this limited to one staff member, one facility? This is where we start to collect a lot of data, whether it be by talking to people or actual going into our electronic records or going out to the floor and with a stopwatch measuring how long something might take. But we start to collect a lot of data. You can see a lot of different tools that can be used during the measure phase. You spend a lot of time actually in a CQI project within the measure phase, just collecting information. One powerful tool in the measure phase is what you would call a value stream map. This is an example of a value stream map. It is a process map that highlights what are all of the steps that are occurring in this process. This is an example of one from a long-term care perspective. The blue stickies highlight what are all of the steps that are occurring. The yellow highlights how much time does each one of these steps take. So now very quickly, I can see what is happening and how long is it actually taking. The red stickies are now the idea of what is all of the waste that is coming in my flow? What are all of the problems that are occurring that are contributing to the bigger problem? If I feel my process is is taking too long, what are all of the red stickies that contribute to taking so long? So you're able to take a big problem and start to break it up into smaller pieces. The third phase of problem solving is the analyze phase. Here we start to ask the question, why? Why am I starting to see these factors occurring? So if one of my if I am facing medication errors as a big issue, well, and I look at my data and I start to see that, you know what, it's mostly during my night shift that I'm starting to see this type of error. In the analyze phase, we start to ask the question, why? Why is it that at night shift we have so many errors? We call this root causes. What are the root causes to the bigger problem? And there's a variety of tools that can be used, whether it be graphical analysis, looking at histograms or Pareto charts, using fishbone diagrams, or a simple tool called 5 whys, which you ask why basically 5 times. Or you could use an FMEA, which stands for failure mode effect analysis, to break down that problem into its root causes. Another powerful approach to analyzing your process is by looking at it through the 8 wastes, trying to identify which of these 8 things are occurring in my process. Because in a Lean Six Sigma world, these 8 things are typically happening in some shape or form in every process. The acronym that we use is called downtime. Stands for defects, overproduction, waiting, non-utilized talents, transportation, inventory, motion, and extra processing. Again, the idea of these things might be happening in any type of process. Might not have all 8, but a few of these will definitely be occurring in any kind of flawed process. And so our goal when we are trying to improve the process is to seek and destroy. Try to find and label where this might be occurring and try to continuously remove them from the process. By doing so, we start to free up capacity. And that is capacity, whether it be time, energy, money, resources that can be reapplied into your process, provide more care to your customers. So now after the analyze phase, someone should have a very good idea as to what are the big contributing factors to your larger problem and what are the root causes to those contributing factors. You are now able to move into the 4th stage, which is improve. How can I start to make some solutions? What are things that I can start to do to resolve the root causes that I have now identified? Now you'll notice here is that we went from typically when people start to solve problems, they go in from the define phase to the improve phase. They'll say, what's the problem? And here's a solution. This is why DMAIC is so powerful, because it forces us to slow down a little bit, collect information, analyze that information before you start to make some solutions. So in this phase, you might be experimenting with a variety of solutions, and that's what we would call PDSA thinking. Plan, do, study, act thinking. Running a series of cycles of changes, experiments to learn more and more about whether or not this solution's working. Now, assuming the solution works, you are very confident that it works, you've seen the impact it has, you're not done. You move on into the last phase, which is the control section. The idea of how do we sustain improvement now? You've made so much work. You've done so many good things. Your improvement is working. The worst thing that we can do now is just walk away. So what are some tools that we can start to apply to make sure that the improvement does not go back to the way it was the next day, the next month, the next quarter? So whether it be standard work, which is kind of like SOPs, whether it be some audits using audit boards, it could be staff huddle boards, the act of bringing people together on a regular basis to review how are we doing. These are other type of processes that can actually be done. Again, in the chat window, please, if you've used any of these tools in the past, I'd love to hear how is it going? How has it worked? Any challenges that you faced with any of these tools, or perhaps they worked very well. So that is the 5 steps of solving problems using a CQI lens. Now, the idea here is then, how can we actually apply this? What are some examples of tools, examples of projects that actually used a lot of these tools? The first example I want to share with you comes from long-term care. There was an an actual long-term care home that had recognized that there was an increase of 62% of medication errors between 1 year to the next. And so using the DMAIC approach and a lot of the tools that I kind of highlighted earlier, what they started to do is start to collect information. They collected data and they realized that on average, they were getting 14.6 errors per month. You can start to see here that the numbers kind of popped up sometime in March and then kind of stayed high. When they looked into the data even more, they measured and analyzed it, they realized a few things. One, they realized that the medication errors were restricted, majority of the errors were due to missed medications. And not only was it just missed medications, but it was missed medications during the supper time, during dinner time. So that was a very powerful insight. So they started to do root cause analysis. Why is it that people are missing doses during dinner time? And they realized that a lot of it is because it's a very hectic time, dinner. There's a lot of things happening. So staff, nurses were just generally forgetting to provide the medication at supper time. So what did they do? They created some sort of visual management. They looked at the way that their forms were set up, and they used color codes to make sure that it's a little bit easier to follow. They also created this very interesting solution, which was every time medications came up from the pharmacy, each bin of medications, this is one bin per resident, each bin would be laying flat. Now, any time that medication is administered, someone would take out a bin and they would administer the medication. The nurse would then return that canister to the shelf on an angle. What does this mean? Well, that means that it's very easy to tell which medications were given and which ones were not. Simple solutions to make it more difficult to do the wrong thing. So long story short, by doing these type of solutions, they were able to drop it from 14.6 to 3 errors per month. That's one example of how these tools can be applied. For the next one, I'm going to hand it off to Ina. Ina?
Great. Thank you, Ali. For this second case study, I'd like to share this story from my experience as a pharmacy manager where I had just begun a new role. A young child had been receiving refills of compounded clonidine from the pharmacy for quite some time. After receiving 1 dose of the most recent refill, the child became extremely drowsy and unstable. The child was taken to the hospital, where it was determined they were likely presenting with clonidine toxicity. As a pharmacist and as a parent, the feeling was absolutely overwhelming. I needed to find out exactly what had happened and to ensure it never happened again. Questions that Ali has talked about so far today came flooding forward. How do I approach this problem? What can I change? What resources do I have? What is within my control? And how do I create an environment of continuous quality improvement? So let's talk about the answers to these questions over the next few slides. The Canadian Incident Analysis Framework gave me a place to start. The steps in this framework helped me to formulate a plan moving forward to improve processes within the pharmacy to ensure patient safety, to support the pharmacy team, and to ensure business sustainability and viability. The first step in the framework is to provide an immediate response and patient support. I provided all the information I could to the parents and the physician to support the patient's recovery. An initial review of documented calculations and weights did not reveal any obvious errors. We definitely needed to dig deeper to understand what happened. While we did this, we outsourced all compounding for children and any compounds with APIs with a narrow therapeutic window. The next step was to conduct an investigation. And this included conducting an audit of the weight of the clonidine trituration on hand to determine if there was a weighing error, a review of calibration records for the weigh scale to investigate if there might have been an equipment failure, All compounds prepared over a period of days, both before and after the clonidine compound was made, were reviewed to determine if cross-contamination may have been a contributing factor. And finally, a review of any other recent error reports and documentation from other prescriptions made from the trituration. Step 3 of the framework is employee management, which was a critical step. The pharmacy staff had been compounding for many years, and I was a new leader to the team when the error happened. Safety culture was a key focus through this whole process. Step 4 was analysis and quality management. An analytical assay of the compound later revealed the preparation contained 10 to 14 times the labeled concentration of clonidine. And step 5 was to follow through and close the loop. On the next few slides, I'll dive a little deeper on step 4 about what the analysis revealed, and step 5, how I followed through and closed the loop. The incident analysis revealed 5 contributing factors or gaps. First, there was an inadequate standard for a final check process, which should have included a process for independent double check by a pharmacist during preparation. This was a key contributing factor which resulted in an incorrect reading of the API or the clonidine weight by a non-pharmacy registrant, resulting in a missed decimal point on the weigh scale. Second, there was incomplete documentation of clonidine compounds made in the pharmacy, which made backtracking of steps somewhat challenging. Third, a culture of safety was not well understood by the staff to facilitate reporting of errors and to focus on designing a safe system to proactively assess the daily risks inherent in the operations of the pharmacy. Fourth, a lack of policies and procedures which incorporated the NAPRA model standards for non-sterile compounding meant different staff members were preparing the compound in different ways. And lastly, but definitely not least, there was a lack of familiarity or training with the preparation of the compound by the staff member preparing the compound. Now that I understood what happened, I faced the questions that many of you have probably also faced. How do I make the changes to the process that ensures safety moving forward within the resources that I have allocated to me? Resources being time, people, and money. How do I support the team to follow through and close the loop? And on the next slide here, as I mentioned earlier, our immediate response was to outsource all high-risk compounded prescriptions to a third-party provider until we completed the investigation and implemented procedures to reduce the risk of occurrence. So how did we close the gap? And when I say we, I do mean we. The team, it's the team, because the change required the entire pharmacy team. The solutions we implemented included growing a culture of safety through education with the pharmacy staff. A discussion on the incident itself was conducted, education on changes in policies and procedures, and regular safety huddles occurred. We also identified training opportunities and conducted regular skills assessment of staff for high-risk processes. Next, we designed a system whereby a pharmacist performed independent double checks for ingredient CAS numbers, weight verification, and compound calculations. We used technology to reduce the risk of another error or confirmation bias when reading the scale. We purchased a weigh scale that printed out the weight of the ingredient to be included as part of the prescription documentation. Next, we designated a compounding area to minimize distractions to the pharmacy staff while compounding or when engaged in high-risk processes. And lastly, policies and procedures were created, which included the NAPRA model standards, and we did this by enlisting the services of a compounding subject matter expert. And on the next slide, you may be thinking, did these changes have an impact? And how did the steps so far consider the Lean and Six Sigma approach? How was I able to make the changes with the limited resources of my labor budget, the time, and the finances? Like many of you, the pharmacy was very busy, but we were determined to find a way. And I can tell you the system changes we implemented created safeguards and opportunities to catch potential errors. Potential incidents became good catches. That meant the safeguards were working. With the standardized policies and procedures, we gained efficiencies in time, which supported the independent double checks by the pharmacists. We experienced less product wastage by detecting errors before compounds were made, and therefore we had less write-offs. With a focus on safety culture and training, an environment was created where the staff felt supported and stayed long-term. These changes led to a reputation in the community as a pharmacy that cared, and the business grew because we did the right thing. The challenges in the short term led to long-term improvements, which helped the business to thrive. And on the next slide. So everything I've talked about so far today was about improving safety at the individual pharmacy level. But reducing the risk of occurrence is about more than just one pharmacy. It's about ensuring other pharmacies can learn from one error. I go back to the learn, share, act cycle that Carolyn spoke about earlier. At our pharmacy, we learned what happened, we learned how to make improvements to our system to reduce the risk of recurrence, but it was important for me to share this learning with other community pharmacists. And in this ISMP Canada Safety Bulletin, I hope that other pharmacists could then review their compounding systems to identify potential gaps and implement their own system changes to reduce identified risks and help keep children safe. Thank you, Ellie.
Thank you, Ina. So these are two examples of how these same tools that you've just been exposed to today have been actually applied in real life situations. So by now, maybe the question that you're asking here is, how do you start to make this change in your own organizations? How do you start to create this culture? Well, there's 4 major things that we would like to highlight for you. The first, creating strategic alignment. Do you and your organization know what's important? What is it that you actually want to drive improvement in? Number 2, based off of those strategic priorities, can you start to work on those strategic initiatives, targeted initiatives, grabbing the right people from those areas that you want to make change, getting them together to start to work on those initiatives? Third, to create a culture, how do you start to adopt CQI as part of everyone's daily work? Things like improvement huddles, or the idea of coming together every morning to have risk mitigation conversations, identifying proactively what are potential risks that might be occurring today. And the fourth being building capabilities, just like you are doing today, getting the skills and the training to get better at CQI. Typically in Lean Six Sigma, there are belts of training. The 3 basic levels are white, yellow, and then green belt. There's also black and master black belt as well. White belt training is for people who really want to know what is Lean Six Sigma. A little bit more knowledge than you would be getting here today, but giving you an idea of what is Lean Six Sigma and what are some of the fundamental tools that can be used. Yellow belt is great for someone who wants to be an active participant. They want to be working on project teams, supporting the facilitator in the data collection, and they would have a little bit more of an advanced understanding. The third level of CQI training would be a green belt level training. This is someone who wants to stand in front of the room. I'm glad to see we have some people on the chat window here today that actually have green belt level training. Very well poised to stand there and be the facilitator of that improvement. So now, based off of that, we recognize that within community pharmacies, this training, it doesn't really exist. There's not that much CQI training for community pharmacies out there. As such, we want to run a quick poll by you. How interested are you in additional education in regards to CQI? We have 3 options that we're going to be posing on a poll shortly. Option 1 would be, you know what, I want to learn more about the fundamentals. This would be something that is perhaps a 1-day session that is giving you a high-level overview of what the tools are applied through some sort of case study. And by graduating out of this program, you would be getting a white belt certification. The second level of training would be a little bit of a deeper 3-day session. This would give you a yellow belt level certification, and teams that would be working in this program would work on a group project and present that group project at the end of the class. The third option is more for the facilitators, the ones who want to actually stand out and lead projects. If this is of interest to you, this would be some sort of program that would be around 6 months long. You would be working on individual projects over the course of that 6 months. And every 2 weeks, you would be partnered with an expert coach who would be walking you through the steps. They would be providing you any guidance, and you would be receiving 5 days of training scattered across that 6-month period of time. So basically, it's 5 days of training in addition to bi-weekly coaching on your projects. Graduates from this program would receive a green belt level certification. So I'm going to ask for the poll to be posted up here. I'd really like to know, what do you have an interest in? Is option 1 something that you are really interested in? Option 2, option 3, or perhaps not interested at all? You might also have another idea, another program idea, in which case I would love to hear what that is. In the chat window, if you've selected other in the chat window, please provide a little bit of a perspective as to what that other means. What is it that you're looking for that is not covered here? So just going to give this a few moments. We have 10 out of 34 people who have responded here. Please, in the poll, just highlight, what is it that interests you? Are you looking at option 1, more of a fundamentals thing? Option 2, a deeper dive, more medium? Or option 3, you want to actually be the person standing at the front of the room running these projects? Okay, we have 19 out of 34 people who have responded, 55%. Let's give this a few more moments. Those who have not filled in the polls, please select which option works for you. Okay. Great, we got a few more here. And I'll give it another 30 seconds. Okay. Again, if you're not interested or you have another idea of what you would love to see from ISMP Canada and the Value Collaborative, please select other. But in the chat window, please highlight, what is it that you're looking for? Okay, just looking at roughly 10 more people. Carolyn? Oh, you're on mute, Carolyn. You're on mute.
Thank you, Ali. We could reassure everyone that the poll is anonymous. We have no way of knowing what they are answering. So please feel free to just pick the one that you would like. And oh, thanks, Denise. Your organization already provides this training. Bravo. There's a question about resource that goes into more detail. Well, if you're interested in more detail, we can certainly work together. And would you like that? Because we can do that, but we don't have one today. What you're seeing from Ali is what we have so far. So, but let us know if that's of interest. I guess we should share because we will have to wrap up. So wherever we're at with that poll, let's share it back to the participants, and if that's possible.
Here's what we have right now. If everyone could see my screen, majority of participants here today would love that 1-day deep session, kind of get a general overview of what are some of these tools. The second being the intermediate QI training, which is a 3-day deeper dive. And then we have not interested at number 3, followed by option 3, advanced training as the 4th option, and then other, 2 people responding as other. Again, if you've mentioned other, please, in the chat window, we'd love to know what other means, or feel free to just highlight that, you want someone to reach out to you after today to ask you those questions. Just flag that for us. Wonderful. Given that we are almost at time here, I want to thank you for those that have participated here today. In summary, I hope you realize the powerful methodology within CQI, whether it be Lean and Six Sigma, how these tools can actually be applied, and how these things can actually better your organization, whether it be monetary or safety or quality of care. These are very powerful tools. And ISMP Canada and the Value Collaborative have a long history of helping organizations like yourselves throughout the entire steps of this journey. So if there's at any point in time you have any questions, you need any support, feel free to reach out to us. As we end this session for today, when you end this session, you will be seeing an evaluation survey. Please, 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 in the nature of continuous improvement, we really do look at the results here. We want to see how we can make these sessions better in the future. So please take the 5 minutes. I've timed it to fill this in. Please let us know. If you have any questions, you may feel free to kind of reach out. But Carolyn, any final words from you?
Well, thank you to everyone. I'd also like a special thanks to Ali, Ina, and to Suma and Vivian for the great support at ISMP Canada and being able to come together to give you this session today. Here is an email address for you. You can reach out to any one of us and we'd be happy to talk with you further. And just stay in touch and let us know if you want to hear more and have other sessions on this or not. Thanks, everyone. Take care. Bye.
Thank you.